Second hearing, proponent testimony. Testifying is, we have we have several members testifying, but first we'll call Michael Stevenson of the National Kidney Foundation.
Good morning. Thank you for Chairman Brinkman for having me here to support the Living Donor Protection Act, House Bill 188. My name is Mike Stevenson. I'm testifying on behalf of the National Kidney Foundation. I'm a board member of the National Kidney Foundation. I'm also a board member of the Central Ohio chapter of the National Kidney Foundation. I live right here in Westerville, so this Ohio House bill I have a vested interest in this. I'm fortunate enough to have a brother who was able to donate to me a kidney. That kidney was donated 25 years ago last month. And my brother had to go through a battery of tests. I'm not going to follow my script, as you guys can read that. I'm just going to give you a little bit more color about myself and my situation in House Bill 188. So my brother had to go through a battery of tests. He lived in Philadelphia. We had the transplant done right here at Ohio State University. Probably about 2 or 3 weeks worth of tests. He had to go through a psychological test, which proved that he was a pretty healthy, normal, young adult, right? We were probably in our late 30s when all this happened. He recently, he wants to retire at the end of this year. He recently went and was taking care of his family affairs and was creating a new will and a trust, and he wanted to purchase a little bit more life insurance for his family, as he wouldn't be supported by his office anymore, and long-term disability insurance. He was denied those coverages, to his surprise, because 25 years ago, he gave me the gift of life. And those barriers to living donation are unacceptable, I think, right now. There are 30 million Americans in the United States that have chronic kidney disease. 90% of those people with chronic kidney disease don't even know that they have it, because it's a silent kind of a disease. Here in Ohio, we have 156,000 people with kidney disease. 13,000 of them are on dialysis. We've had in excess of 2,200 people on the transplant list. 1,100 transplants were performed last year. So less than half of those that are asking for a transplant are giving a transplant. We're trying to remove the barriers for people to give a living organ, whether that's a kidney, that's a lung, that's a heart, that's anything. Johns Hopkins did a study that said 25% of those individuals who tried to either get life insurance or change their life insurance policy or long-term care policy were denied coverage only because they had been a living donor. We should be encouraging living donation, not discouraging living donation. And the more barriers we can reduce to living organ donation, the better off we're going to be. Ohio has been very supportive of organ donation in the past. I know that we've passed bills to have tax deductions for expenses when you travel or become a living donor. We also have the Family Medical Leave Act that allows people to get their job back if they're taking time off to be a living donor. Let's not stop there. Let's pass this bill and move it over the finish line. We think that those on Medicare, we can save around $60,000 for taking an individual off dialysis and giving them a living donation and putting them on immunosuppressant drugs. $60,000 per one individual. You know, it just seems like this is a no-brainer to me. I get it that I can't get life insurance. I'm okay with that, right? I'm happy to be alive right now because of my brother, but there should be no reason that he can't get additional life insurance. We're 25 years out from our transplant. There doesn't seem, he's, you know, the spitting image of me, so we don't have any comorbidities, we're not obese, we're not doing anything that we shouldn't be doing, right? We're eating healthy, we're healthy individuals, and there should be no reason that he should be denied life insurance or long-term care insurance. And the last things that I guess I will say is that why do we need this legislation? So to me, the insurance industry, and take no offense by this, but it seems like there's an arbitrary decision on the rules and who gets to follow the rules and who they apply to. And I think with this bill, we can eliminate that gray area in the bill to help people understand that they can reduce the barriers to living donation. I think also if this saves one life in the state of Ohio, why wouldn't we want to do that? So 18 states have passed this bill already in the United States, and there's several on the docket, like right here in Ohio. There is really no opposition to this bill. The insurance companies are in favor of this bill. So I really believe that we should continue to support House Bill 188. Tell potential donors in Ohio that you want to protect them and save the life of Ohioans. Shouldn't cause them to worry about their future. Living organ donors should not be penalized for the altruistic act to help a friend or family member in need. Thank you for your time, and I'll answer any questions if I can.
Thank you. Are there any questions from members of the committee? Seeing none, thank you very much for your testimony.
Thank you so much.
Next, we're calling Nicole Harris, Corey King, Dr. Steve Little, I guess, from UC Health. Step forward when you're ready to begin. We appreciate your coming.
Thank you. Chairman Brinkman, Vice Chair Lampton, Ranking Member Miranda, and the members of the Ohio Health Insurance Committee, thank you for the opportunity to provide proponent testimony for House Bill 188. For the sake of brevity, I've submitted our written testimony. I would like to hit a few key facts. I know that Mr. Stevenson hit a lot of our statistics earlier, and I will not hit those, even though they're very valid as well. But I'm Corey King. I'm the transplant administrator at UC Health. And I have brought with me the director of our program and surgeon, Dr. Steve Woodle, and one of our kidney transplant nurses, Ms. Nicole Harris, who's also a living donor herself. The UC Health transplant program provides kidney transplantation, including living donation, liver transplantation, including living donation, and we also do pancreas and heart transplantation. We are one of the largest centers in the United States, and we do a lot of living kidney donors as well. So that's a big part of our program. Nationally, 108,000 people nationally are waiting for an organ donation, or either deceased or living donor. And 80% of those are kidneys. We are not getting that gap different on 108,000. It's been consistently about 108,000 because we're not able to get as many kidney donors as we need to help the many people that need a kidney donation. Currently, living donor transplantation is the best treatment for patients with kidney failure, as it provides them with rapid means to avoid future dialysis treatments and provides the longest time off of dialysis. As Mr. Stevenson mentioned earlier, dialysis is not cheap, and it's costing a lot of people a lot of money. And as the administrator, I have to reiterate that that is a lot of money that's going towards Medicare, Medicaid, and our private insurers as well. So getting people off of dialysis quicker is not only best for the recipient, but it is also good for the economy and the insurance industry as well. House Bill 188 would expand this access to patients that need organ donation by protecting the living donors from insurance discrimination. Mr. Stevenson mentioned previously in the previous testimony that there are many states, 18 in all, that have done something similar. And there's also federal legislation as well under the Living Donor Protection Act that is currently pending. Around Ohio, our neighbors in Pennsylvania and in Kentucky have recently signed similar bills. House Bill 188 is a laudable step in the right direction for the state of Ohio that addresses protections that living organ donors need. UC Health strongly supports this bill, and we look forward to continuing the work of the Ohio legislature on expanding protections for living donors in the future. If I may yield the floor, I would like to yield the floor to Dr. Steve Woodle, who is our director and one of our transplant surgeons.
Thank you, Corey. It's a pleasure to be here today. I'm Steve Woodle. I am a multi-organ transplant surgeon. I've been doing kidney transplants for 33 years. I'm the director of solid organ transplantation at UC Health in Cincinnati. I'm also a professor on the faculty at the University of Cincinnati. I'm also a transplant recipient, having received a liver transplant 17 years ago. So I've been through the types of processes that we're talking about today. What I wanted to do was embellish on what Corey did and put you in the place of a practicing surgeon who sees patients, a few to several hundred patients a year who need a transplant. When a patient comes to my clinic, the number one thing I want to achieve for them is to get them off dialysis or prevent them from going on dialysis at all and get them a transplant, preferably a living donor transplant. Why a living donor? They last longer. They decrease the amount of time that you spend on dialysis. Every year you spend on dialysis, you lose survival. You lose life expectancy. So the best thing for a 20-year-old that comes to me is to get a living donor transplant that lasts them 20 to 30 years. Not an average deceased donor transplant that will only last them 10 years. At the age of 30, they're looking at a second transplant. And then a few years after that, a third transplant. So the first transplant, being a living donor transplant, is absolutely critical for almost everyone. I have a personal universal goal to do living donor kidney transplantation in every patient that has renal failure. When we look at the things biologically that prevent us, like blood type or having immunity to another person's kidney exchange programs and modern therapies like desensitization have removed many of those barriers. In fact, now 20% of every living donor transplant in the United States is a kidney exchange, where they've exchanged kidneys to get around the wrong blood group. But when we come down to it, we get to the finances and we get to the problems. There are many barriers that persist financially that are disincentives to living donors. There are the costs associated with travel, lodging. Transplant centers are in metropolitan areas. They're not in rural communities where many people live. There's also a family member that often needs to leave. They leave work. There's lost wages, and there's child care and elder care expenses. Then when you see those problems and they start stacking up for a living donor, and then they start thinking about, well, I'm not gonna be able to get insurance, life insurance. I've got kids at home. I've got a wife. You can start to understand this is just one of another barrier that we need to address. We appreciate the time and effort that the committee has taken, and we encourage them to strongly consider removing this barrier to living donation. Thank you.
Thank you for your testimony.
Hi, my name is Nicole Harris, and I was fortunate enough to be able to donate a kidney to my mom on May 15th, 2012. I'm also a transplant nurse coordinator working with kidney patients before they get a transplant. My personal journey with kidney donation was rough, to say the least. I watched my mom get very, very ill. She had to be resuscitated on multiple occasions as well. And part of the reason for her health declining was that we knew she would need a transplant, and the waiting times for a deceased donor transplant were going to be 2 to 3 years, plus possibly up to 5. I knew from the beginning of my mom's diagnosis that I was a match for her, But due to my parents' fears of something happening to me, even though I was an adult, that was met with a lot of aggression and delayed, I don't want to say hostility, but just refusing to accept a kidney from me. During that time, when she was on dialysis, like I said, probably about 2 years, her health declined significantly. Finally, I just kind of took on becoming a donor on my own, along with the transplant center, and found out that I was able to donate, and that happened on May 15th, 2012. Hearing my mom's story, my parents' story about not wanting to have a child donate is a common thing that we hear with our transplant patients that we're working up these days as well. And one of the things that would be able to say to potential donors or to parents is one of the things with lessening the financial barriers and lessening the concerns about potentially this person not getting insurance coverage unless this bill gets passed. So thank you for bringing this up, and we fully support it, and I would donate again in a heartbeat, but it would definitely have been an ease of mind to know that this was in place. Thank you.
Great, thank you for all of you. We have questions, now some will probably go to different ones of you, so that's okay. Yes, Representative Frost.
Thank you, Mr. Chairman. What, I don't know, but thank you all for your testimony. What is the cost of surgery for, is there a cost to the donor when you're donating a kidney? My brother-in-law donated a kidney to my father. Was there a cost for the donor?
Representative Brinkman, Representative Cross. So we do not bill the donor insurance for any of the workup or any of the surgery. The cost of the evaluation and the cost of the surgery itself and the inpatient stay is on the recipient insurance.
Follow-up, Mr. Chairman. What's the value of a kidney? What do you think the cost and the value of a kidney is today? Let me help you answer that question. Priceless, right? I think it's pretty priceless. For someone to donate a kidney, it's tough to put a value on a living organ, but I would think all organs are pretty priceless. But then when they turn around, that donor turns around and wants to get a little extra insurance, and getting denied, the math doesn't seem to work. Thank you, Mr. Chairman, for allowing me to answer my own question.
Yes, Representative Patton.
Thank you, Chairman. Good morning to all three, and thank you for coming in. It's been a long time since I really talked to anybody about transplants, and I know that in certain sectors, especially among some minorities and some folks from other parts of the world, it's a little harder to get matches. I understand that when you did your mother's, what is the connection? For example, I have 5 daughters at home. If I needed a kidney, what would the likelihood that one of the 5 would be? And is it less stringent? You seem to imply that there's some other types of things to help people not reject or be able to accept something that might not have been 15 years ago.
I think you're asking the question, what are the chances one could donate to me? From a biological perspective, they're actually pretty high. Even if we identify a potential donor for you and they don't have the right blood type, we participate in the largest kidney exchange program in the world. It's the National Kidney Registry. This year they'll facilitate 1 in every 10 living donors in the United States. So when you go into that, you and your donor go into that registry. You can go in with 2 or 3 donors or as many donors as you want to. They will then use computer algorithms to find you a potential match, somebody you could swap the kidney with. We don't actually do mutual swaps now. They're actually cascades where somebody who wants to donate to just anybody donates a kidney, and then that gets cascaded down. Although if you're O blood group, it's tougher. For a person that's an A or B blood group, it's pretty easy to get them transplanted. So it's the ways, it's well established now, and 1 in every 5 living donor kidney transplants in the United States is a kidney exchange.
Follow-up, Chairman.
Yes.
So the O blood type, which I always thought was like the common one you could use for, that's actually tougher to find donors for that. I'm saying that as an O positive blood type myself, so that's a little disconcerting.
Yeah. It's a supply-demand issue. When you're looking at blood type incompatibility, most people are O recipients and they can't receive an A or a B. You know, an AB recipient can receive any type of kidney. An A recipient can receive an A or an O. And so there is a premium for O kidneys going into it. One of the ways that's been addressed is to allow altruistic donors, donors who want to give to anybody. They come in and 40% of them are O blood group by national statistic, just statistical average. And so there's been strategies employed to address that, and they haven't completely mitigated the problem of being an O recipient in kidney exchange, but they've substantially lessened it.
Final question, sir? Thanks, Mr. Chairman. I know that there was always the rejection theory and that people that get a transplant will have to be on medications, plural, you know, for the rest of their life. Has that improved, or is that, and is that still pretty much a mandate? And how many pills, and what is like the approximate cost for those anti-rejection type, you know, medications?
It's a very good question. People have thought the overall patient survival and graft survival weren't improving much, but Jesse Scholl and Emilio Poggio of Cleveland Clinic just published a very important paper a few weeks ago showing that over the past 20 years, every 4 to 5 years, there's incremental improvements in patient survival and in kidney graft survival. So we're getting better, and the immunosuppression's getting better. It's tough to overcome the rigidity of the FDA to get new medicines. But we're getting better. The whole field is improving, and it's just a lot. We have better drugs to treat infection. We have a lot of things that we're doing now that are just better. Our tissue matching is a lot better. So there's been technological improvements other than immunosuppression that improved a lot of transplant recipients.
Thanks, Doctor. Thank you, Chairman.
To the chair and to the witness, is there an age limit for donating?
You want a short answer or a story?
A story. I like stories.
When I was at the University of Chicago over 25 years ago, we wouldn't let anybody over 65 donate. We had a hard, fast stop. And I had a coordinator come to me and said, Dr. Woodle, I've got 2 lawyers in the room, and the wife needs a kidney. And the husband says, if you don't let him donate to her, he's 72, that he's going to go find somebody who will. So I went in the room and listened to him, and they had worked all their lives and wanted to travel the world, and now she came down with renal failure and she couldn't travel because she's linked to dialysis. And he told me straight to my face, he said, he was a hard-time litigator, tough guy, you know the type. He said, if you don't do this transplant, I'll find somebody who will. He was in pretty good health. So we listened to him, this is what they wanted, and we ended up doing that. 72-year-old donor, never done it before. Oldest before that was 65, and they traveled the world. So we listen to patients. We don't have a strict cutoff. We look, it's not chronological age, it's biological age. It's how good a health and physical condition are you in. So no, we don't have absolute cutoffs.
Thank you.
Thank you, Chair. Thank you so much for your testimony today. My question is a practical one on just if you had existing life insurance prior to donating your kidney. And based upon what I'm reading, I read all the written testimony to kind of get a perspective on this. You will literally be in a position where the insurance company will pull your life insurance upon noticing or upon, revealing that you indeed gave a kidney or were a living donor. Can you speak to how this happens, or can you speak to what are some of the complexities? I mean, I'm just trying to understand, if I had life insurance, because I'm an organ donor in terms of having on my driver's license, but if I gave a living, became a living donor, I had life insurance, I may have been paying on it for 10 years. And then immediately upon successfully giving that organ, I'm dropped from my insurance. I mean, I guess I'm just trying to understand, how often does this happen? Do you all have any perspective on that? Can you even have any personal perspective? I would love to hear from you. Thank you.
Yeah, I think the major problem with the life insurance companies won't know 1 year to the next when you come for a premium what's happened to you medically. So keeping an existing policy is not as big an issue as going to get new coverage, whether it's disability, life, long-term care. That's where they're going to want to have some medical condition information. What I can tell you is that from an insurance industry standpoint, the risks of developing renal failure and the risks of dying with living kidney donation are known. They're in the literature. That can easily be taken care of through a statistical calculation. And so these numbers are in the literature and they can be found for insurance companies. So I can't see where that's not a problem, that they can't spread out over premiums over an entire population.
Any additional questions? Seeing none, thank you very much for your journey up here and for testifying for the bill. Members should see on their iPads that they had submitted to us written testimony from Melanie Lindwall, American Kidney Foundation, Jamie Bell, Charles Miller, MD, Cleveland Clinic, Elizabeth Lively, dialysis patient citizens, Dr. Witham, assistant professor of medicine, and some other folks with the Kidney Disease Foundation and University Hospitals. To read those. Is there anyone else here to testify on House Bill 188? Seeing none, our business is concluded.